We had a session today about survivorship, and my topic was about bone health. And I think this is something that is sometimes a bit forgotten. So we know that we have really increased survival in breast cancer and in prostate cancer, but that also means that obviously the consequences of our treatments are much more important now. And we know that bone health is especially important for patients with breast cancer and with prostate cancer, because both the disease but also the treatment can harm the skeletal integrity. And so we know that a lot of hormonal treatments do really have a negative influence on the bone, so there is bone loss, and we should actually treat it. So, but sometimes that just got forgotten because someone has cancer and then everyone is concentrating on the cancer, but not of the side effects of the cancer treatment, right? So we had an interesting session just to speak first about the cancer treatment-induced bone loss. So this is mostly by aromatase inhibitors and also ovarian suppression for breast cancer patients, but then also for androgen deprivation treatment for prostate cancer patients. And we do know that actually one of the most important things is changing lifestyle. So you should stop smoking and you should drink less alcohol and do more exercise. It's very difficult to do that, but apart from that, we should also measure bone mineral density and do really assessments for risk factors for fractures, and then try to get to normal vitamin D levels and then maintain them, and use bone targeted agents if it's appropriate, and there's good guidelines when you should do that. So I think this is something we should really think about if we have patients with either breast cancer or prostate cancer who start on a hormonal treatment. Because we know, osteoporotic fractures are really bad for the patients and for the quality of life. So that was one of the important points. And then there was another kind of topic that it's a bit related. It's about patients who have bone metastasis. And we know that there are substances like denosumab and like zoledronic acid that you can give, and you reduce the incidence of symptomatic skeletal events. That's how it's called. And we use these substances since more than 2 decades, but actually we don't know what is the best use of them. So we're still treating all the patients the same, even if there are very different situations. They are approved in a monthly schedule, but we're not sure if really that much is needed, and they have side effects as well. One of them is ONJ. And we heard today that the risk, the incidence of ONJ is about 3% after 3 years of treatment, and that's not a nice side effect. So we have a lot of studies ongoing to try if we can give these substances less often, so every 3 months instead of monthly. And actually for women with metastatic breast cancer, it has been shown that probably the 3 monthly zoledronic acid application is as good as the monthly one, and then you have so much less dose, but also means so much probably less toxicity. So that's why this is very interesting, and now we're working also on looking for the newer substances for denosumab. So we have in Switzerland a study looking again for 3 monthly versus monthly application of denosumab. But these data are not finished yet because we have only 900 out of 1,400 patients recruited. But we really hope that we can reduce the dose and therefore then also reduce the toxicity.